So good evening, everyone, and welcome to today's webinar series on fast nutrition, kidney nutrition. I think this will now be our 5th webinar series, but overall for the AHN webinar series, we are at 169. My name is Dr. Yuri. Okay, I'll be moderating the session for today. And we're going to tackle a very interesting topic on dietary phosphate management, and we'll be looking at case-based insights. And we do have our guest speaker today. This is not her first time, Dr. Annabel Biruete. She is an assistant professor and a registered dietitian in the Department of Nutrition Science at Purdue University, and an adjunct assistant professor in the Division of Nephrology, the Indiana University School of Medicine. Her broad clinical interest is nutrition in kidney diseases, and Dr. Biruete's research aims to study the effects of nutritional and pharmacological therapies for chronic disease on gastrointestinal tract and gut microbiome. Additionally, she is interested in improving outcomes in the Hispanic Latin community living with chronic kidney disease, primarily through language and culturally concordant lifestyle interventions. And today her audience will be majorly in Sub-Saharan Africa and the rest of Africa. And so we're looking forward to a very enlightening discussion on matters dietary management and phosphate. Over to you, Dr. Biruete.
Thank you so much again for the invitation. It is a true honor to be here again. And I'm going to shift gears now from gut health more into the dietary management of phosphorus, which is a topic that I've been doing some research over the last few years, and particularly the overall chronic kidney disease, mineral and bone disorder. So I have some case studies from some colleagues that I will incorporate early so you can start thinking about how to manage phosphorus in these two cases. So these are my disclosures, and let me put my laser point. So in today's talk, I will explain to you how phosphorus fits into the chronic kidney disease, mineral and bone disorder. Then I will move into a little bit of the evolution. You will see that across the years, we started being very restrictive, and luckily that has been changing. Now we're more nuanced into how we manage phosphorus, and I will end on how do we manage phosphorus right now? So I will start with two cases. These are in collaboration with my colleagues at the Indiana University School of Medicine, two dietitians there that are not renal dietitians, but they do see renal patients. This is a case of a non-dialysis dependent stage 5 CKD patient, which is 75-year-old African-American male, lives with significant other, has chronic kidney disease stage 5, in addition to HIV, COPD, Hep C, and hearing loss. There are some relevant lab values, including high blood urea nitrogen of 76, a creatinine of 6.43, a GFR of 10. Again, this is a non-dialysis patient, a phosphorus of 4.6, and an albumin of 3.7. He has several teeth that are missing. His BMI is 22.27. And in the diet history, you will see that at least in the United States, we have several of these patients that tend to consume a high ultra-processed food diet. And you see in this patient. So there's a lot of consumption of snacks, particularly sweet snacks. There's a lot of deli meats. There is a lot of foods that we kind of like think about: sodium, potassium additives, phosphorus additives, etc. So for example, the breakfast was a smoked sausage with rice and 2 cups of plain oatmeal, lunch meat sandwich with a white hamburger bun, dinner, a hamburger with a hamburger bun and cream corn. That was a can of cream corn. Snacks, these zebra cakes, these Debbie snacks are really popular here in the United States. I'm not so sure in Africa. And beverages, you can see that he consumes a lot of sugar-sweetened beverages. So I just want you to think about what would you highlight if you're thinking about chronic kidney disease, mineral and bone disorder, and particularly phosphorus management. The second one is a case of an emergent dialysis patient. This is a Hispanic patient, 50-year-old male, has a history of end-stage kidney disease, undergoing dialysis now, more on the incremental side. So he started on lower doses of dialysis. He has fluid overload, hypertension, diabetes, hyperlipidemia, and a BMI of 25.5, history of anemia. The labs important to highlight, again, the high BUN, the high creatinine, high blood glucose, a higher phosphorus and a lower calcium, and a higher hemoglobin A1C. This is a type 2 diabetes, a patient with type 2 diabetes. Some of the food and nutrition history that the dietitian wanted to highlight is that it has a lot of support from a significant other, from his wife. And they are doing a lot of the traditional renal diet. So they avoid whole grains. They avoid dairy products, coffee, chocolate, convenience and packaged food, and some sugar-sweetened beverages. He takes 3 meals that most of them are prepared with by his wife. And the diet recall is a lot of foods that are traditionally consumed at home. So contrary to the history in the last patient, there is minimal ultra-processed food intake. So for example, the day before he had an egg, a green chile, potato for breakfast, fish, zucchini, carrot for lunch, white rice, chicken, and carrots for dinner. The dietitian was able to provide some Spanish handouts. So again, I just want you to think about what would you do, what you wouldn't do, what would you change in terms of the treatment for this patient. So starting really with chronic kidney disease, you are probably really well aware that it's a systemic disorder, as the name implies, of mineral and bone metabolism. It is characterized by 3 components, which are the biochemical abnormalities, the bone abnormalities, and the extraskeletal calcifications. The biochemical abnormalities are exemplified in this graph. So just to orient you, on the x-axis, we have the stage of kidney disease going from less kidney disease or no kidney disease to kidney failure, stage 5. And on the y-axis, that biochemical parameter either increasing or decreasing. You will see a very faint gray line, which marks the normal range. And you will see that early on in about stage 2 to stage 3, we have an early rise in fibroblast growth factor 23, which is a hormone primarily produced by osteocytes. This is a phosphaturic hormone, so it signals the kidneys to increase the excretion of phosphorus to maintain phosphorus within the normal limits. At the same time, you see that there is a drop in the active form of vitamin D, or 1,25-D hydroxyvitamin D. And one of the reasons why this drops is because FGF23 is a very strong inhibitor of 1-alpha hydroxylase, and that 1-alpha hydroxylase is the enzyme in the kidneys that causes the second hydroxylation and activation of vitamin D, and therefore that's why we see a drop in this active form. In moderate kidney disease, so in stages 3 and 4, you see this increase in parathyroid hormone, which is another phosphaturic hormone, but it is really until stage 5 when these hormones are not able to maintain homeostasis, and a lot of our patients develop high levels of phosphorus in blood. The bone abnormalities can be related to turnover, so how much bone is formed and how much bone is resorbed, and the balance between those two. When patients, for example, in kidney failure, have higher levels of PTH, this turnover goes more to the resorption, therefore there's more brittle bones. In terms of the volume, that means the quantity, and the mineralization more on the quantity. And because of these biochemical abnormalities and the bone abnormalities, our patients calcify where they shouldn't be calcifying, particularly the cardiovascular system. So it's not really by mistake that we focus on phosphorus and all of these biochemical abnormalities. Really is, although it's one of the biochemical abnormalities that develops late in late-stage kidney disease, there are several mechanisms in place to maintain that homeostasis, and I mentioned PTH and FGF23. However, these both increases are not benign, as we know, and hyperphosphatemia is also not benign. So for example, if we think about high levels of phosphorus, that high level of phosphorus causes a significant loss of kidney function, and also it is related to more vascular calcifications. The high levels of PTH is associated with more fractures, again, because there's more resorption in the bone. And the high levels of FGF23, that hormone produced by the osteocytes, has been causally linked to more left ventricular hypertrophy. All of these factors have been associated with more cardiovascular events and more mortality, and we know that the main cause of mortality in our population is cardiovascular disease. So that's why we focus on controlling this. And while dietary phosphorus is not the sole component contributing to serum phosphorus, it's really one of the main contributors. If we think about if a patient that is on kidney failure, we're really not having that mechanism to excrete the excess of phosphorus to maintain phosphorus within the normal limits. So therefore, dietary phosphorus becomes very, very important. We know, and we were talking about some of the phosphate binder medications that limit the absorption of some, but not all of the phosphorus. We also have some medications that control bone resorption, limiting that calcium and phosphorus coming out of the bone, but it's again not enough. If we also think about a patient that is undergoing hemodialysis, maybe they only go 2 or 3 times to dialysis. So therefore that treatment is not enough to keep up with all of the phosphorus coming either from the food or from the bone. And our GI tract is not able to excrete that excess through feces. Particularly, we think that a lot of our patients have constipation, therefore they cannot excrete that. And additionally, well, we would hope that our gastrointestinal tract adapted to these signals from phosphorus homeostasis, especially because of the high levels of FGF23 or the high PTH and the lower vitamin D, active vitamin D. Relatively recent data from Dr. Hilgeland's lab showed that in patients with stages 3B and 4, compared to match controls, healthy controls, they were matched for sex, age, and race. Unfortunately, the fractional absorption of phosphorus in the intestine measured with radiolabeled phosphorus was very similar. So they are absorbing exactly the same as a person that has normal phosphorus homeostasis, has no increase in PTH, FGF23, or lower vitamin D. So therefore, we need to think about ways in order to maintain or limit the absorption of phosphorus. And you probably all know this, but the phosphorus recommendations and the renal diet have really come a long way. This is a timeline of the major things that have happened in case of the renal diet. And you can see that a lot of it was dominated by a very restrictive era, particularly thinking about low protein diets. Like in the 1930s, the protein restriction started. Then this was a very unique diet that was based just in rice, fruit, and sugar and protein-free diets. Then the traditional low-protein diet introduced by Giovanetti and Maggiore and another set of investigators focused also on high biological proteins, which were given mostly in the form of eggs or some dairy. Then the late Dr. Zlatopolsky in 1972 had a lot of research in dogs with kidney disease, and he had the trade-off hypothesis suggesting that in order to maintain all of the CKD and BD biochemical parameters like PTH and phosphorus, you had to do a restriction that was relatively similar to the loss of GFR. But that meant that in people with severely reduced GFR, you almost had to ingest 0 phosphorus, which is, that is very, very hard in people with kidney disease. Then in 1973, the father of renal nutrition, Dr. Joel Koppel and Coburn, did a lot of inpatient ward studies in which they gave various low protein diets limited with specific minerals that I will talk about in the next few slides. In 1994, either your favorite or your least favorite study, the MDRD study, the Modification of Diet in Renal Disease study, which was a US NIH-sponsored study that really went into look into what happened when patients consume low-protein diets. So in a lot of these studies, even though phosphorus was not the main focus, the main way that phosphorus was restricted was with a low-protein diet. Then in 2003, in 2000, and then in 2003, there were the Kedoki bone metabolism guidelines that suggested a specific amounts of phosphorus consumption. And then it was really in 2003, so about 20 years ago, that doctors Mona Calvo and Jaime Riveri started introducing this concept of not all sources of phosphorus are the same, which is really what is dominating how we manage phosphorus in the present. And then the KDIGO guidelines for CKD and BD and the nutrition guidelines from Kedoki in 2020, but that went into a little bit more detail into how should we manage phosphorus recommendations. So I'm going to go through a little bit of these to give you a little bit of an idea. So in the past, a lot of the actually the studies started from postmortem recommendations. And they suggested that because there was a lot of calcifications in some of these renal structures, it would make sense to focus on phosphorus restriction. So they did studies in animals. And this figure on the left, it was a remnant model rat without phosphorus depletion. So you see a lot of calcification and immune infiltration in the renal structures. And when they gave a very severely restrictive phosphorus diet, so this was a 0.7 phosphorus, this was a 0.04 phosphorus diet, in addition to aluminum hydroxide, which is a binder that it's not used anymore, they showed that the calcification in the renal structures was almost non-existent. Going into some of the clinical trials, this is the metabolic ward study that I mentioned, in which they tried two types of protein diet. So one is 20 grams, which is very low, and the other one was 40 grams, which is still pretty low if we consider that, at least in the United States, our mean weight can be between 80 and 100 kilogram person. So in this control feeding study, they showed that these 20 and 40 grams, which corresponded to about 550 milligrams of phosphorus in the 20 gram and about 800 milligrams of phosphorus in the 40 gram diet, that protein that was lower, so the 20 gram, most of the patients were either on a neutral or a negative phosphorus balance. Whereas in the 40 grams, there were some people in negative balance, but some other that were more on the positive side of the balance. And this was statistically significant between both groups. This patient population was stage 5, but without kidney dialysis. And then again, I mentioned the either your favorite or your least favorite study, the modification of the renal diet, the MDRD study, in which they had two studies. The study A was comparing a traditional normal diet, which was really on the higher end, so a diet with 1.3 grams per kilo per day, compared to a low protein diet, which was about 0.6 grams per kilo per day. And the study B, which was that low protein diet, or 0.6 grams per kilo per day, compared to a very low protein diet, which was 0.4 grams per kilo per day, supplemented with alpha keto analogs. And they showed that in the short term, there was a drop in the urinary phosphorus, both with the low protein and the very low protein diet. So this is study A and study B. And also there was a small but significant drop in serum phosphorus in the short term, so in the first 4 months. However, when you see the following months of follow-up, so 1 year, 2 years, and 3 years, you see that the urinary phosphorus was pretty much maintained, whereas the serum phosphorus was starting to increase, suggesting that there is a rapid decline first, but then there's like an increase over time in serum phosphorus. So when did phosphorus restriction really become practice? And we think about restriction, but it's not really restriction. It's restriction from traditional intake, but it's not restriction from what the guidelines recommend. So if we think about the RDA for adults, it's 700 milligrams per day. However, we've seen in epidemiological studies that they report that the intake is well above the RDA. So this is in data from Enhanced, what we eat in America, in ages from 20 to 39, 40 to 59, and 60 plus. In blue are males, and in orange are females. You see that all of them are well above the RDA. So most of them consuming more than 1,000 milligrams and getting closer to 1,500 milligrams. So really, the restriction is from the usual intake, but not from what we recommend. And if we look into what our foundations and several organisms and organizations recommend in order to get to that dietary phosphorus restriction, they usually recommend, these are for dialysis patients, recommend animal protein, thinking about that high biological value protein and thinking about the amino acid losses during the treatment. They recommend refined grains because the whole grain contain a lot of the phosphorus. They recommend rice and almond milk instead of dairy milk because dairy contain higher concentrations of phosphorus and potassium. And they recommend low phosphorus dairy foods like butter, cream cheese, heavy cream, and non-dairy whipped topping. However, if we look into the opposite side and what to avoid, they usually recommend to avoid whole grains, high fiber foods, most dairy, nuts, seeds, dry beans, legumes, and lentils. And also they recommend restricting phosphorus additives. And when we did a systematic review of what was available online in terms of these patient resources that they can get in the internet, Facebook, etc., we actually found that the overwhelming majority of this education resources reflected similar guidance, meaning that most of them were very restrictive towards an overall restriction without the nuance about where the phosphorus is coming from. And what did it mean to follow these restrictive recommendations? Typically, these were met in the lower protein diets. It was easier to get to the lower phosphorus and low protein diets, but the collateral damage was that there was a restriction of what we traditionally consider a healthy diet. So there was a lot of restrictive whole grains, legumes, nuts, seeds, and dairy. And this is very restrictive to some cultures. So speaking from experience and from where I'm from, I am from Mexico, and a lot of our staple foods are a lot of plant-based foods, for example, beans, for example, tomatoes, and thinking about more potassium and other things. But a lot of the foods that we tell them to restrict are the foods that they're used to consuming. So this may also enhance some level of stress around food. And also we know from a lot of epidemiological data that high diet quality is associated with health benefits, even in the context of a kidney disease. And if we're telling our patients to restrict a lot of these foods, what are we really leading them into? So a greater adherence to a healthy dietary pattern is usually associated with lower risk of CKD progression and all-cause mortality. So usually this higher diet quality is associated with a high consumption of fruits and vegetables, nuts, legumes, fish, low-fat dairy, whole grains, and a lower consumption of red meat, processed meat, sodium, and added sugar. But these sources, nuts, legumes, fish, low-fat dairy, and whole grains, are sources of phosphorus. So what are we really doing? And in fact, if we looked also into some more epidemiological data, when we restrict phosphorus, when we do a more restricted diet with phosphorus, actually that's associated with worse outcomes in patients. This is data from the HEMO study in which they surveyed the dietitians. They asked them what was the prescribed phosphorus for their patients. And you can see the representation of what the dietitians were given, but you see that were more on the 800 to 1,000 milligrams, kind of like following the guidelines from in 2003 were the Kadoki guidelines for bone management. Some dietitians also didn't do any restriction. They were like, there was no restriction. And when they did the assessment of either the survival or the mortality, those that had a more restricted diet actually had worse survival. And those that had no restriction or a least restricted diet had better survival. And the data that really actually started to shift a little bit of the focus on an overall restriction of phosphorus was this data from Dr. Schöneberger published in 2008, suggesting that those that had a restriction of protein and phosphorus, so that overall restriction, had actually worse survival. So the risk of controlling serum phosphorus by restricting dietary protein intake may outweigh the benefit of a controlled phosphorus and may lead to a higher mortality. And we know that the restriction of phosphorus is really, really challenging. Sometimes with our patients, we have the lack of knowledge related to food and nutrition. In a lot of instances, we have limited access to nutrition education and counseling from a registered dietitian. In the United States, we have a lot of general dietitians, but we don't have enough renal dietitians to cover the whole CKD population. We do very well in our dialysis clinics, but when we are expanding to more a preventive service, we don't have enough dietitians trained in this area. Also, some of the limitations is that the phosphorus content is not required in the nutrition facts label. So the only requirement is that the phosphorus ingredients are included in the ingredient list, but we don't have a quantity of phosphorus. There's also a widespread presence of phosphorus in the food supply, particularly phosphorus additives. And there's really a lot of conflicting nutrition and health messages from you should be consuming a healthier diet, but at the same time, you should be restricting whole grains, nuts, seeds, legumes, etc., because of their content of phosphorus. So that is really confusing to patients. And also, we know that our patients, unfortunately, have several comorbidities. So it's not only the kidney disease, it may be the cardiovascular disease, it may be the diabetes, it may be other things also that they're dealing with. And this may lead to patients feeling frustrated and also leading to a reduction in quality of life. So luckily, that is slowly changing. And instead of doing an overall restriction of phosphorus, we have focused into more nuanced recommendation. And this started with several clinical trials. This is probably one of the most important ones it's listed on the guidelines on why we should be focusing on the types of phosphorus, where the phosphorus is coming from. This was a small study relatively. It was a crossover trial of a diet with meat. So that was the main source of phosphorus versus a vegetarian that contained a lot of those sources of phosphorus that we traditionally restrict, considering like legumes, nuts, and seeds. In stages 3 and 4, they consumed this tightly controlled diet. So it was a control feeding trial for 7 days. And then they brought them into the inpatient ward. They measured the homeostasis of phosphorus, so phosphorus, FGF23, and PTH. And they gave the same amount of phosphorus. This was more on a restrictive phosphorus diet, or I guess a regular phosphorus diet of 800 milligrams per day. And they showed that there was a different concentration of serum phosphorus. The meat diet had a higher concentration compared to the vegetarian diet, suggesting that perhaps this is the way that we can lower phosphorus in our participants. And the current recommendations, thinking about the KDIGO guidelines for CKD and BD, and then the nutrition guidelines from KDOKI, and I also think now the 2024 KDIGO guidelines for the management of kidney disease, they're very similar in the recommendations of phosphorus. All of them kind of follow the 2017 KDIGO guidelines that says that in adults with stages 3 to 5D, we recommend adjusting dietary phosphorus intake to maintain serum phosphate levels in the normal range. This has a recommendation level of 1B, so fairly good. And that it's reasonable when making decisions about phosphorus restriction treatment to consider the bioavailability of phosphorus from sources, comparing animal versus vegetable. But this was an opinion because there was not enough evidence, even though that previous study was included in the guidelines. But what does that mean? What does taking the bioavailability or bioaccessibility mean in the context of kidney disease? So this is focusing on where the phosphorus is coming from. There's a lot of in vitro data, not a lot of clinical, and a lot of reviews saying that the bioavailability of some foods is higher than from others. So thinking about those that have a lower bioaccessibility. So now I'm using these terms interchangeably, but bioaccessibility is the phosphorus that it's available for intestinal absorption, whereas bioavailability is actually what is you can see in blood, and it's bioavailable for tissues. So a lot of the evidence that we have on the differences in foods is really coming from in vitro studies. So just the amount of phosphorus that may be able or available for phosphorus absorption. Maybe I'm just complicating too much, but really the data that we have is on bioaccessibility. And this suggests that those foods that have a lower bioaccessibility are coming from plant-based foods. So those foods that we traditionally restrict, like the whole grains, legumes, nuts, seeds. So these foods, their phosphorus is in the form of phytate. And the phytate has all of the phosphorus, but our small intestine does not have the enzyme necessary in order to release that phosphorus to be available for absorption. There is some bacteria in our gut that contain that phytase, but our small intestine percent does not have it. So because of that, the amount of phosphorus that our intestine is able to get is lower than if we consume, for example, a phosphate additive. So some things to consider is that if these foods are high in phytate, How do we prepare the foods? Because some other things may enhance the phosphorus from the phytate. So for example, if we cook it, there may be some release of phosphorus. If we have some fermentation, like for example, in a sourdough, if we add some yogurt, that may also enhance the release of the phosphorus from the phytate. Some of the processing that is performed for prepackaged foods can also enhance the release of phosphorus. The portion size obviously is very important. The phosphorus density versus the phosphorus richness. So phosphorus density means the amount of phosphorus compared to the amount of energy. And the phosphorus richness is really the amount of phosphorus within a specific portion of food. So thinking about this, there's a lower phosphorus bioaccessibility in plant-based foods. Foods with a moderate phosphorus accessibility are animal-based foods that have the phosphorus not in the phytate, because these foods do not contain phytate, but it's more on phosphoproteins, and these are more easily digested and more easily absorbed. So things to consider here are the processing, the portion size, and cooking techniques. And really the ones that we should be avoiding are the foods with phosphorus containing additives. And that is because there's nothing limiting the absorption of these. With this, what we should be considering are the portion size, the ingredients, the foods with naturally containing additives versus additives and modified ingredients. So instead of the past of phosphorus management, which was an overall restriction of phosphorus, now what we focus on is in this kind of like qualitative gradient of some foods that may have less bioaccessible phosphorus versus those that have a higher bioaccessible phosphorus. The other thing to consider is when we are with people, can we tell them something that may limit the phosphorus from their foods? And that is, yes, we can use some cooking techniques that can lower the phosphorus in foods. So this was a study performed in different types of animal meats. So they use beef cuts in blocks, slices, or cubes. They measure the phosphorus, protein, and phosphorus to protein ratio before and after. They did several types of boiling in pans and pressure cookers. They use different types of water, so soft water, hard water, acetate solution, and bicarbonate water. So key things to ask our patients, do you know if your water is soft or hard water? At least here in the United States, in the areas that we live, our water is really hard. And how long? Depending, they did some trials, 10 to 30 minutes. So what worked better? So actually, they showed that compared to raw meat, those that were in soft water had a 50% reduction in the amount of phosphorus. They also showed that if you sliced and cooked for 30 minutes, they were able to drop phosphorus concentration by 64%, which was pretty significant. And also, if they sliced and cooked in the pressure cooker, they were also able to lower the phosphorus concentration by 66%. So this is something very easily that we can tell our patients in terms of they are consuming a type of food, like for example, a meat that is known to contain a significant amount of phosphorus. And as I mentioned, now the focus is more on restricting those phosphate-containing additives. And this, I really like this study because even though it was in a healthy population, it was a control study that they provided all of the foods. They compared a minimally processed food compared to a highly processed food enhanced. They call it the enhanced diet because they contain phosphorus-containing additives. The enhanced diet, even though there were very similar foods, just switching those that had either a phosphate additives or not, they showed that the enhanced diet increased the amount of phosphorus intake by 600 milligrams per day. And you can also see how different it was. So this is day 1, day 2, day 3, and day 4, and the amount of phosphorus that they gave. So in the low additive, they still gave a pretty significant amount of phosphorus, about 1,000 milligrams per day. But in the enhanced diet, they went up to sometimes 1,800 milligrams of phosphorus. In addition, in those that had the phosphorus containing additives, we know that several of those additives are compounded with sodium. So you can see also the difference in the intake of sodium. And we know that in our patients, we tend to also give them a lower sodium diet. So if we are limiting phosphate additives, we can also limit the amount of sodium additives that they're consuming. And even in healthy adults, they showed that in the enhanced diet, after the consumption of these phosphate additives, they showed an increase in FGF23, meaning that they were able to give this load and showed that there was a load significant enough that FGF23 was up in order to enhance the phosphorus excretion in urine. Again, this was in healthy adults. And in data, epidata, just to kind of like give us some evidence that limiting phosphate additives is good, this was a study, the Diet HD, which included data from 10 European countries and Argentina. It was a food frequency questionnaire, and they did the analysis into what was the amount of phosphorus consumption and the risk of mortality. So they showed that when phosphorus intake goes up, the ratio for mortality also goes up. However, when they split into where the phosphorus was coming from, comparing phosphorus coming from processed foods, they also showed that the proportion of phosphorus coming from processed foods was associated with a higher risk of overall mortality in these patients with hemodialysis all over the world. So, and just by limiting phosphorus additives, can we improve serum phosphorus? The answer, at least in the study in hemodialysis patients, was yes. This was published in JAMA in 2009, and it was a study of 14 hemodialysis clinics in Ohio that included almost 300 patients. And it was a very simple study. They provided educational resources, and they gave them a magnifier. So the patients read the ingredients in the processed foods that they were consuming or buying in the store, and they told them to avoid anything with the phosphate additives. In the US, we tell them to avoid those that contain the PHOS in any type of ingredient, and they just avoid those. And they showed that after 6 months, they were able to lower serum phosphorus by about 0.6 milligrams per deciliter, which was statistically significant compared to the control. So I know that I said all of these evolution of the phosphorus management, it has been very restrictive. We're going more on the nuance side of phosphorus management, trying to avoid those phosphorus-containing additives. And we need to also mention that a restricted diet or a restriction does not mean or necessarily mean a restricted diet. If we limit phosphorus by restricting foods with additives, we can actually also reduce the consumption of some other nutrients that we're trying to reduce, particularly with thinking about sodium and now some potassium additives as well. So in our view, that is a win. We can also take advantage of lower phosphorus by accessibility in foods to recommending lowering phosphorus intake. And I think this may be very relevant in your countries in which you have a higher availability of plant-based foods that are traditionally consumed in your population. So there are some things that you could do in order to promote the consumption of those foods, but also to limit the amount of phosphorus. We also have to use more patient-centered approaches for any dietary recommendation, taking into consideration culture and traditions. I told you that at least in my culture, the renal diet is very restrictive because we tell them not to consume beans, not to consume tortillas, for example, because it's a whole grain, not to consume a lot of the fruits and vegetables because they may be also higher in potassium. So this ends up being very restrictive and stressful for our patients. However, with everything, I mean, we do more long-term clinical trials, but clinical trials with dietary interventions are really challenging. I show you data from control feeding trials, which often do not translate into the usual consumption of patients. So while I obviously promote more clinical trials, you probably also know that behavior change is one of the hardest things to do. So now going back into our patients, this non-dialysis CKD patient was consuming a lot of highly processed foods. And this patient was in stage 5 non-dialysis treatment. So we needed more of a lower protein in order to conserve the function, in order to also, this was patient didn't want to go into dialysis. So we needed to do something in order to improve symptoms. So thinking about the protein that the patient was consuming and going to a lower protein diet, thinking about the foods that this patient was already consuming, things to highlight are that a lot of these foods were also containing phosphate-containing additives. So this is something that we can educate and try to find other sources of the similar foods that he's usually used to consume in order to lower the load of phosphorus. In our emergent dialysis patient, this patient was actually was following the recommendations, was consuming not a lot of additives. It was actually not consuming a highly processed diet. A lot of the foods were cooked by his wife, and they were avoiding a lot of things. However, we could also probably do some reintroduction of foods, particularly the whole grains, which we know that the phosphorus in those foods may not be easily accessible, meaning that the availability of phosphorus is not as much. So the challenges with this emergent dialysis patient obviously is that the ultrafiltration is less often. There's more accumulation of electrolytes, minerals, and nitrogenous products, but possibly better preservation of residual kidney function, which is also important for excreting that phosphorus. Some of the nutritional recommendations, thinking about conservative management, particularly in those non-dialysis days, sodium restriction to avoid phosphorus overload, and thinking about phosphorus bioavailability, and also thinking about the quality of life of the patient. So to conclude, an overall dietary restriction leads to poor outcomes. Current dietary phosphorus management is centered around the bioaccessibility or bioavailability of food, of the phosphorus, and less restrictive and may impact phosphorus management. But as always, clinical studies are needed. But again, behavior change is different. So clinical trials in this area are also challenging. So that's all I have. So I'm happy to answer questions. Thank you.
Oh, thank you, Dr. Annabel. That was quite an enlightening discussion.
Thank you.
It was nice to actually see the journey from the past to the present, and with different milestones and where we have come from. And I think very good research that is being done in that area, and very nice, very good developments. Probably I can start with a question on my
Yep.
side. There's this school of thought that mostly colored foods have high phosphorus. I think for beverages, we know something like dark colors, for example, do have high phosphorus. But there's an argument on whether, even for eggs, for example, where if you look at either the free-range chicken versus the caged one or versus the pasture chicken. So if the eggs are more yellow, being told probably let them do the ones that are, yes, yellow. If, for example, in East Africa, we have patients who take a lot of yams, which I think are colored, they are a bit purplish. And then we also have sweet potatoes, which are really yellow, and they are
Yep.
white ones. So there's always an argument also for patients who, for example, take maize, yellow maize versus white maize. So is there any, I'm not sure whether it's a fact or just an hypothesis or a school of thought, that should we avoid more of the yellow ones and do more of the whites? What are your thoughts on this?
That's an interesting question. I've never heard about that, but to me, I mean, a lot of the color really comes from phytochemicals. So it
Okay.
is more not really related to the phosphorus content, but more on the chemicals that give that color to the specific food. So thinking about the sweet potato versus one that it's more on the purple side, it's really the phytochemicals. In terms of the eggs, a lot of people were like, or avoid the yolk because that's where most of the phosphorus is. And I mean, yes, I mean, it's not an incorrect argument. The phosphorus, it's mostly in the yolk, but at the same time, it also contains a lot of nutrients. So an egg is really a nutrient-dense food. So I would not avoid that in our patients. Can we limit some other things rather than the plant-based foods that, in addition to phosphorus, it's also giving some other nutrients that they need? I would take more that stand than restricting specific colors, if that makes sense. I mean, in my mind, I interact with a lot of researchers that does research in phytochemicals, and these phytochemicals are also beneficial for example, the gut. So I would go more on the let's not restrict based on color.
Makes sense. I think it's just because I've had a lot of nutritionists when I go around also advising patients to avoid that side. So I just wanted to seek a clarification. So
Yeah, and that's
thank you
an
for
I've
that.
never heard of that, but it's interesting. Yeah.
Yeah, thanks for that response. I'm seeing there's a comment by Dr. Hadija. I think just asking for help with dietary recommendation for renal transplant patients. Not sure. I think we're supposed to probably have that in another discussion, but probably you can tackle it, Dr. Annabel.
Yeah, so in a lot of instances, sometimes we think, oh, they have a kidney transplant, they can do whatever, but no, we are trying also to preserve the function of that kidney transplant. So for those patients, I would go more on the healthy eating guidelines, not being as restrictive because probably they came from a lot of restrictions if they underwent dialysis or if they went to more of a conservative management. Give them more room to eat more of the foods that they want to consume. But probably in terms of phosphorus, I would probably avoid a lot of the phosphate containing additives in ultra processed foods. Again, thinking that they may contain more sodium, that may contain more phosphorus additives, and they may also contain more potassium additives. So trying to restrict or avoid those probably would be easier, but I would go more on the healthy eating guidelines with those patients, not being very restrictive.
Thank you for that response. There's another question that asks, actually from Beta, Dana Beta, that's one of our nutritionists. She's saying, thank you for the nice presentation and explaining that she had a patient who was measured with a low phosphorus level and was given a certain medication to raise the phosphorus level. So her question is, do you think it was necessary? And what do you usually do when the patient is measured with a low phosphorus level in your practice?
That is a really interesting point. And actually, some of our PD patients deal with this. And more of a note, I am not practicing currently, so there's nothing that I do in my practice currently. I do only research at the moment. But just talking with my colleagues that are practicing, a lot of them use actually phosphorus supplements. So it's giving actually the phosphorus additives in order to increase. In my point of view, I would probably go more on the phosphorus dense foods. So thinking not the colas or the processed foods, but those foods that naturally contain phosphorus. So perhaps giving a little bit more of, if the patient likes eggs, give them more eggs. If a patient consumes more meat, probably give them more meat. And give them with all the meals and see how the phosphorus goes up or how the trend goes. If that does not work, then think about, okay, what else can we do? Can we add some of these foods that contain a little bit more phosphorus, perhaps for that patient may be beneficial. But again, at the end of the day, we don't want to just like supplement and supplement and supplement. If we can do something with the whole diet to enhance the phosphorus intake, we could do that. That is obviously the opposite problem that we have with most of our patients, but that's something that, for example, also in children, some people in nephrology do. Try to do more phosphorus density and then add some of the phosphorus supplements.
Thank you for that, Dr. Annabel. I think the last question that I'm seeing in the chat box is asking from a participant by the name Violet, asking who is responsible for CKD patient nutrition. To me, I believe it's kind of multidisciplinary. A nutritionist, the nephrologist needs to be on board, but of course you can weigh in on this.
Yeah, so ideally you will have always a person that has a training in nutrition. So either coming from a registered dietitian. We do have usually the first point of contact is the physician or another healthcare professional. So having somebody that buys into nutrition and also has some education in nutrition, that would probably be very important. But if you ask me, the primary person responsible for managing nutrition in a patient should be a person with significant training in nutrition. So if that is the physician, if it's a registered dietitian, obviously the registered dietitian. But again, like Dr. Yuri mentioned, this is a multidisciplinary. So usually having a buy-in from a physician for us is really helpful. If the physician says nutrition is really important and then refers to the dietitian, probably the likelihood of that patient doing good is better than if the patient says, oh, nutrition does not work. So hopefully it will be a multidisciplinary with the primary lead being a registered dietitian or the equivalent.
It will make sense. There are no more questions. I don't know whether we have any questions from our panelists. Maybe you can unmute and ask. Yes, Professor Bima.
Thanks. So this is going to be this news is a bit inflated by the fact that the general pediatricians are prescribing probiotics for everyone. And so I just want to know, what's the impact of these probiotics on phosphorus metabolism?
That is a very good question. And actually, there's not a lot of research, but there is some evidence that some strains of probiotics may be better for handling phosphorus, and specific strains that have a polyphosphate gene within those strains. For example, there's Lactobacillus plantarum that may be beneficial because it actually needs phosphorus in order to keep growing and maintaining their colony or whatever. That has been shown in animal models, not yet in clinical populations. There's also some evidence from environmental engineers that treat high levels of phosphorus in water that have been used on probiotic strains to lower the phosphorus content of those waters. But those effects in people with kidney disease have not been explored to date that I'm aware of. But that's an excellent comment. I mean, there's some beneficial effects on inflammation and gut health, etc., but specifically targeting probiotic treatment for CKD and BD management has not been done.
It's what I ground for research. Okay, thanks. I appreciate that.
Thank you.
Thank you, Dr. Annabel. I know you have other matters to attend to, so I beg to close. I hope I haven't closed out anyone, but I just want to say thank you to Dr. Annabel again for making time for another enlightening discussion. And on behalf of Africa Healthcare Network and our panelists, I want to convey my thanks and wish again to have you more in other future discussions. So it's very important in terms of capacity building and again, learning from you and your expertise. I'll also give it to Dr. Lloyd for any closing remarks. Thank you.
Thanks very much, Annabel. Thank you very much. The shift and focus of phosphate management, the bioavailability, the bioaccessibility, very important aspects. Thank you very much. It was a wonderful session. And we will have this up on YouTube. At the same time, is there a possibility you can share some slides, Annabel, that we can give it, distribute it out? So
yeah, I can share my slides.
Yeah, generic. So it's something that is simple and understandable. So practice change can occur, especially nutrition and the physicians. It will be very, very helpful. These are very important concepts that you need to push through in practice, right? And a lot of people also have missed this session. So I would like to actually pass it on. Very important concepts.
Thank you so
Extremely
much.
grateful
I'm happy to share.
Yeah, thank you so much. Thank you. And I will pass it across the board, right across all our database. And it's a very, very important concept that you've actually pushed today. The whole change, the paradigm shift that is occurring in phosphate management, not the protein restriction, but focusing on the phosphate per se and the gut. Thank you so much.
Thank you so much again for the invitation, and thank you. Have a great day.
Thank you.
You too.
Thank you so much.
Bye.
Bye.